Today we're going to talk about another question of the day for you. Go ahead and pause the video, read through this question, and unpause when you got an answer. Okay, first thing we do whenever we're approaching questions, or at least what I do, free country, do whatever you want. I start with the last sentence, which is usually the question part. So which of the following changes in hemodynamic parameters would you expect in this patient? Good God, so bad at reading. Then the next thing I do is I like to look at the answer choices. Very briefly, sometimes it gives me an idea of what system we're looking at. Here, it's one of the scary up-down arrow questions, so we know that we're in for a doozy. This is probably going to be a shock question. Just looking at some of the columns here, cardiac output, SVR, PCWP. So this is most likely a shock question. So next up, we're going to go up, read through the stem one time. I'm going to try and identify anything that I think is important, and then we'll talk about it as we go. Okay, so 65-year-old man, that's good to know. Sometimes age is important. Confusion and generalized weakness. This is interesting. It almost starts off as a neuro question when you get started. Then they tell you he has shortness of breath. That's always important. When lying flat, so he's got orthopnea. That's a good indicator of probably some kind of heart failure. Maybe lung pathology, though. You can't just chalk it up to cardiac. It could be pulmonary. No chest pain. That is interesting. No fever either. Probably not a septic shock, although that's not the only criteria for it. No cough. Maybe not pulmonary. Recent illness or trauma. Great. There was a lot to unpack in that sentence. Okay. Medical history includes all of these fun things. It's CHF. There it is. So from that alone, I can probably estimate that he's got a cardiogenic shock. Honestly, I think the rest of this history is unremarkable. Here, we've got sort of like an objective findings going on here. We've got our vitals, 120 beats per minute pulse. He's tachypnic and hypotensive, 80/50. So definitely a shock question. JVP is 10. So good to know your normal reference range is around 6 to 8 centimeters. So this is elevated JVP. And we've got bilateral crackles on lung auscultation. Crackles can mean one of two things for the sake of boards. On one side, they can mean pulmonary edema. On the other hand, they could mean an interstitial lung disease. So keep that in mind when you see crackles. I definitely add that to Anki if you don't already have that in there, because that can really help you with your differential list. Okay, that's all we need for sure. Going through this again, there's no fever, so probably not septic shock. Started off looking like neuro with the confusion and weakness, but that could just be signs of shock. So probably not a neurogenic. No hypovolemic. There's no signs of trauma. So this is probably, my guess would be a cardiogenic shock with that congestive heart failure history. Okay, so there's a few things you need to do whenever you're approaching these shock questions. I'm going to give you my top secret formula here. Top secret formulae. So first thing you need to do is remind yourself of the two systems that acutely regulate blood pressure. All right, Dora the Explorer time. What are those? Just kidding. I'm not going to make you wait. So the first one would be the heart, or your cardiac output. And second would be the vascular tone, or your SVR. These things respond rapidly. Normally when I ask students this question, what are the two systems that acutely regulate BP? I almost always hear RAS, aldosterone. That is not going to be acute. The fluid retention that happens with RAS is a slower process that usually takes a couple of days before you start seeing changes in blood pressure. I'm thinking sympathetic outflow, heart and vasculature going to respond immediately. Next thing you have to do is ask yourself two questions. Do I feel lucky punk is not one of them? You should be wondering, which one of these systems that we just mentioned is the problem causing the hypotension? And then subsequently, which of those systems is trying to compensate? So with cardiogenic shock, the typical presentation that they give us is chest pain, neck pain, jaw pain, left arm pain, whatever, any kind of sign that he's having an active myocardial infarction. Here they say there's no chest pain. So that could really throw you off. It threw me off a little bit at first, but with the history of congestive heart failure, that's kind of the way they bring you back towards the cardiogenic side of things. This could just be an acute decompensated heart failure. You don't necessarily need to have a myocardial infarction to have cardiogenic shock. So keep that in mind. If it looks like cardiogenic shock, presents like cardiogenic shock, just go with it. Even if it doesn't tick all your boxes for what you suspect it should look like. So the problem with cardiogenic shock, as the name suggests, would be the heart. So when we're doing here, what's the problem causing the hypotension? It's the heart. There's something wrong with the heart. In this case, this guy's got CHF, probably some sort of acute decompensation. Now, next up, the second question. Therefore, or subsequently, which system is trying to compensate? There's only one left, right? We picked the heart for A, got to be the SVR. That's it. That's literally the super dummy way to go about it. If cardiac output is the problem, there's nothing necessarily wrong with the vasculature. So it's going to try to constrict to preserve blood flow to vital organs. So heart is the problem. This is our heart, our cardiac output. So we need to find one with a down arrow. That means right away we can cross off A. It looks like I underlined it. Way to go, me. Cross off A, and we can cross off B. So we're down to 3. Next up, SVR needs to be compensating, which means SVR has to increase because we are vasoconstricting. So it can't be E. We're down to C and D now. The only difference is our wedge pressure. Briefly, pulmonary capillary wedge pressure is essentially an estimate of the left atrial pressure. We put a catheter in through maybe the femoral vein, thread it all up through the IVC into the right side of the heart, get it in the pulmonary trunk, the pulmonary arteries, and it pretty much stops there. We can't really push it through the capillaries without killing people. So the courts don't really like that. So we do a little math-o-magic with our catheter in the pulmonary trunk to estimate the pressure in the left atrium. So whenever you see pulmonary capillary wedge pressure, or PCWP, it just means how much pressure is in the left atrium. So if you have a cardiogenic shock, be it a heart attack or acute decompensation, in this patient, they specifically mentioned that he has heart failure. So we know that his heart is not working very well, which means he's not able to pump out blood as well as a normal heart. Therefore, the blood is kind of pooling in his heart. It's accumulating maybe in the left ventricle, maybe backflowing into the left atrium and the lungs, which could explain those crackles that we heard of maybe a pulmonary edema, pulmonary congestion. And that can continue to backflow into the right side of the heart. That can cause the JVP, the elevated jugular vein, and even a peripheral edema if it was bad enough. So in this case of cardiogenic shock, we should be thinking that wedge pressure is going to be increased because blood is getting stuck essentially in the heart. So that is C, and that's all she wrote for today. Thank you for watching.